Dr. Parikh sir, Dr. Mathur, and Dr. Jyotirmay Pal, Dr. Parikh, our patron, our godfather, our mentor, who have always been insisting us to continue the CMEs. I will like to ask Dr. Parikh to say few words to boost our morale and the audience, so they will remain connected with us for the next program also. Dr. Parikh sir.
Thank you, Dr. Keswani. And it's my pleasure and a great honor to welcome all the delegates who are attending this prestigious program, certificate course on obesity. At the outset, I would like to welcome our dynamic president, Dr. Girish Mathur, and very energetic dean of ICP, Dr. Jyotirmay Paul, and our very learned speaker and a endocrinologist of great repute, Dr. Sahay. Thank you very much for joining us, Dr. Sahay, and sparing your valuable time for this program. Thank you very much. It's really great to have you on our program. This is the vision of our president and our dynamic, energetic Dean ICP, Dr. Jyotirmay Paul, to have certificate courses to disseminate the knowledge to everyone, and especially on obesity, which is really one of the biggest risk factors, not only in India, but also globally. And the childhood obesity, for which we are so much concerned, reason for all the non-communicable diseases. So it's one of the very important and very big risk factor for all the diseases which we are having in today's time. So to aware our doctors, and so that we can aware public also through them, that the obesity is one of the biggest concern, and the simple formula to know what is your weight. You can ask every patient, take his height, and height in centimeter minus 100 is the approximately weight of the person. So how much weight he is to lose, you can suggest him. Although I know that most of the patients do not like this advice, but still, when we persist, we can do something for this society. So really a great thing to talk about our the person who is doing this all certificate courses, Dr. Prakash Keswani, who is a learned person, is an excellent teacher and a very good human being. He has already done last year such certificate courses, many diseases on the platform of ICP and API. And the feedback which we got, that these courses are very good for postgraduates, for clinicians and everybody. So we again started with the vision we had of our president and dynamic secretary, dynamic dean ICP, that we should start such courses. And we have a very learned person to talk on the first talk on obesity, Dr. Sahay, and he will be telling everything about the obesity. So thank you very much, everyone, for attending these courses, and I hope that we'll be much more learned persons after getting this, and will be helpful to aware our public about the obesity. Thank you very much. It's a big epidemic, and we must try to help the society to reduce this epidemic to a great extent. Thank you very much. Jai API, Jai Hind.
Thank you, Parikh sir. Thank you for your kind words. Now I will turn over to the Dr. Girish Mathur sir, who is the dynamic president of API. He is a very strong man, always boosts us for various academic activities. And this year also, in last 3 months only, we are able to see so many changes in the API as such and academics also. I will request Dr. Girish Mathur sir to say a few words for the members of the API as well as our audience. Dr. Girish Mathur, sir, please will you.
Thank you, Prakash ji. Good afternoon, friends. It's my proud privilege to welcome you all on behalf of API and ICP and the certificate course on obesity by ICP. Honorable Dr. K.K. Parikh, Dean ICP, Dr. Jyotirmay Paul, the man behind this program, Dr. Prakash Keswani, Dr. Nandini, Dr. Rakesh Sahay, and friends. I wish to congratulate Dr. Jyotirmay Paul, our Dean, to take this initiative to start this ICP certificate course. And I also congratulate him to start many innovations in ICP. He has formed a global forum where many neighboring countries are part of this global forum. And we are going to start many programs under the banner of ICP and API. He started a newsletter where all the publications, latest information, state activities will be published every 3 months. And he has got many plans also in future in ICP. I congratulate him for his dynamism and energy. Obesity, as we all know, has emerged as a major global health problem, and its prevalence has grown to an epidemic proportion, with over 4 million people dying each year as a result of being overweight or obese. And obesity was considered once a problem only of high-income countries, but its incidence has grown dramatically in low and middle-income countries, especially in urban settings. And one more concern is the prevalence of obesity in children and adolescents. I'm sure this certificate course of obesity will go a long way in updating our physicians about the approach and control the menace of obesity. I also want to take this opportunity to share with you that API has started a membership drive where the membership fees of life membership and PG membership has been reduced dramatically. We are offering a significant discount on the membership fees. Please spread the word to your friends and colleagues who are not members of API to become members of this premier organization. Secondly, we are also going to publish a API directory this year. So I request you all to send the updated information about the addresses, phone number, and mail ID of yours to API headquarters by mail or by phone number. Thank you so much for inviting me to this program. Thank you, Prakash ji, again.
Thank you, sir. Thanks a lot for your kind words and for reducing the fees. And this will enhance our membership drive. And now I will request our Dean ICP, Dr. Jyotirmay Paul, who is really a dynamic man, as Dr. Girish Mathur told. In the last 3 months, new website launching, newsletter, and these certificate course, all are being closely monitored and stimulated by him. Dr. Jyotirmay Paul, will you like to please say a few words for all of us?
Thank you, sir, for inviting me. And it is really my proud privilege. Dr. Girish Mathur, President API. Dr. K.K. Parikh, our mentor, past President API. Dr. Prakash Keswani, most very dynamic and energetic academician and governing body member. Dr. Rakesh Sahay, Dr. Nandini Chatterjee, Joint Secretary, Dean's Place, and all the delegates. This is really we deem it as a proud moment that 2023 we are again going to start the short certificate course. Indian College of Physicians, the academic wing of API, is trying to start many new academic ventures to update our members so that they can do the best clinical practice in India and will be recognized. And what Dr. Mathur said, we are also have established a global forum so that people from Indian, what is happening in the outside India, maybe a small country, we can learn, and also for our expertise can be used by other foreign countries. This is the very basics of the global forum. We will work together, and the subject chosen by Dr. Prakash Keswani is really time honored, because after independence we face the challenge of undernutrition. But this century we are facing the dual problem. In one hand undernutrition, and other hand overnutrition. So obesity management is becoming a challenge, because during 1947 the two-thirds of the death was due to the communicable disease, one-third non-communicable disease. But now the two-thirds death due to the non-communicable disease and one-third due to the communicable disease. So we have to reduce the mortality and morbidity out of non-communicable disease, and obesity is one of the key disease among this non-communicable disease. So we have to prevent obesity, we have to treat obesity. So I hope this type of short certificate course, our practitioners who have joined will be hugely benefited. Thank you, Dr. Prakash Keswani and Dr. Rakesh Sahay, for taking this pain. Thank you.
Thank you, Dr. Jyotirmay Paul, for your kind words. Now I would like to invite Dr. Rakesh Sahay, who is the key speaker for today, and he was flying out today, and he has managed to give his talk here only with us. And Dr. Rakesh Sahay, will you like to say a few words? He is the professor and head of the endocrinology, Osmania Medical College, and he is the president of Endocrine Society of India at present, and president-elect of National RSSDI. Dr. Rakesh Sahay, will you like to say a few words about the obesity? And
thank you, sir. Thank you, Dr. Keshwani, sir. And at the outset, I would like to congratulate Dr. Parikh, sir, Dr. Mathur, sir, and Dr. Jyotirmay Paul for initiating this very important program. As we all know that obesity is a major public health problem today, and it is a driver for the epidemic of not only of diabetes, cardiovascular disease, cancers, and all the other host of other problems that are happening because of obesity. So I think it is very important that we tackle obesity. We look at obesity right at the time before all these problems set in, and try to change our lifestyle and bring about a change in the population health. So that is why I think this program has been initiated, and I congratulate all the API, the ICP, and obviously the leaders of these organizations for initiating such an important program. And I also congratulate Dr. Prakash Keswani, who has taken the initiative. He has conducted these certificate courses very efficiently, and I congratulate him once again for conducting this important program, and thank him for inviting me to be part of this. Although he is going to be the key speaker today, he's going to give us an overview about obesity, tell us all about obesity. I'm just going to speak a little about how to evaluate obesity, how to make assessment about obesity. So over to Dr. Keswani. Thank you, sir. Once again, thank you for having me here.
thank you, Dr. Rakesh. Thanks for your kind words, your moral boosting words. And as all have told that the obesity has come out as a health crisis, and it is not a simple weight gain, but it leads to development of a number of other various complications. And without wasting time, we will now move towards the first talk of the today. And Mr. Ajay, will you permit me to share?
Yeah, please, sir. Please, sir.
এটা কি দা তোমার
Ajay's
And
I think So very good afternoon to all of you. In this part of today's session, we shall be discussing obesity, a simple introduction of the obesity, what it is, how we can measure it, why we are worried about the obesity, and what health implications can be because of the obesity. Coming over to the chronic food shortage and malnutrition have been the scourge of humankind since the dawn of history. The current worldwide epidemic of obesity is now recognized as a public health crisis, is barely a few decades old. Obesity word comes from Latin obes stars, means fat or plump. Even around 2000 years back, Hippocrates gives his view on it and wrote that corpulence is not only a disease itself, but the harbinger of others, means obesity is not a simple disease, but carry out so many other diseases. Now coming over to what is obesity. Obesity is defined as a state of excess adipose tissue, normally around 10 to 15% of body weight in males and 15 to 20% of the body weight in females is of the adipose tissue. If the adipose tissue is in excess of it, it is obesity. But we are not able to measure this obesity or adipose tissue directly. So we, in the clinical practice, we take other proxy measures like body mass index. Fat tissue can be measured by the bioelectrical impedance or whole body DEXA scans. BMI is highly correlated with the body fat and is related to diseases and is associated with morbidity and mortality. Lower BMI thresholds for the Asia Pacific region are recommended since this population appears to at risk for glucose and lipid abnormalities at lower weight. The traditional theory of energy balance, we know that if the calorie consumed are more than the calorie used, there will be weight gain. And on the other hand, if calorie used is more than the calorie consumed, there will be weight loss. If there's no weight change, means calorie consumed is equal to the calorie used. Now coming over to the epidemiology. Worldwide obesity has nearly tripled since 1950-75. In large multinational clinical trial in 2016 showed that around 39% of adults aged 18 years and above were overweight and 13% were obese. Around 39 million children under the age of 5 and over 340 million children in the age group of 5 to 19 were overweight or obese. So we can see a big proportion of the population comes under this category. And what is about India, that here again we have good proportion, good prevalence, and women have been found to be affected more and they are more obese. So that if we see the prevalence in the men and women, there's clear-cut predisposability for the women. Women compared to the men are more likely to be diagnosed with the obesity and seek and obtain all types of obesity treatment. Man, if is also obese, he usually takes care of it less often. Greater prevalence of obesity in women becomes only manifested in adulthood, with peak prevalence occurring between the 60 to 65 years of the age. Higher prevalence of the severe obesity again has been found to be in the females more as compared to the men. Obesity is more prevalent among older women than men, and the difference is around 26.3 to the 17.6%. Higher proportion of older women had higher waist circumference and waist hip ratio as compared to the men. So we see that women are more prone for development of obesity. It's more prevalent in women. Severe obesity is again more prevalent in the women, and waist circumference and waist hip ratio is also found to be more in women. Coming over to the assessment of obesity, it will be discussed in detail by the Dr. Rakesh Sahay. Most often we use BMI. It's a simple measure, and it is commonly used measure of overall adiposity in the clinical setting. Its validity is in measuring adiposity is less well established in children, where the BMI is usually on the lower side. Similarly in the elderly people and those who are more muscular. Waist-hip circumference ratio, commonly known as waist-hip ratio, is a surrogate measure of intra-abdominal or central obesity. Predicts long-term disease risk in both men and women, independent of BMI. Waist circumference is recommended as the most practical tool to assess abdominal fat or central obesity. You can see that normal weight we can see is 18.5 to less than 25. 25 to less than 30, we measure it as a overweight. And if it is more than 30, it is obesity. Then it, according to the severity of obesity, class 1, class 2, or class 3 can be there. Another method of measurement is waist circumference. It is recommended as the most practical tool to assess abdominal fat or central obesity. Excess abdominal fat assessed by measurement of waist circumference is independently associated with a higher risk for metabolic syndrome, diabetic mellitus, and cardiovascular disease. Measurement of waist circumference is a surrogate for visceral adipose tissue, and a simple measure of fat distribution can be obtained by waist-hip ratio. So by these simple measures, we can measure the weight, BMI, obesity, and the central obesity. This, if we see the distribution of the fat, in normal females also, more fat deposition is over the abdomen, what is called as central obesity or apple-shaped obesity. While in the man, more fat is deposited over the gluteal region and the thigh, what is called as pear-shaped obesity. And in the pathological conditions, in the obesity, more fat deposited in over the abdomen, what is called as visceral obesity, central obesity, is found to be associated with so many comorbidities and complications. Sometimes even when BMI is within normal range, having too much fat around the abdomen will still put one at risk for heart disease and diabetes. What is called as apple-shaped obesity is related with so many complications. And the target for the waist circumference in Indian women is less than 80, and for the man, it is less than 90. While examining these patients, simply weight, height, waist circumference, waist-hip ratio, and of course, there are certain other things we can easily see in our clinical settings. One is acanthosis nigricans. This is a blackish velvety pigmentation present over the back of the neck and in the flexors of the neck. In hypothyroidism can be, they are dry, scaly skin. Acne can be present in the PCOS or Cushing's disease. Bruises can be present in the Cushing's. Hyperpigmentation again can be indicative of Cushing's. Xanthomas or the xanthelasmas can be present because of the hyperlipidemia. Skin tags, as are seen in this second diagram, are indicative of the insulin resistance or hyperinsulinemia. So these simple markers can help you to find out presence of insulin resistance or hyperinsulinemia. When energy intake exceeds energy expenditure, a small amount of that excess energy is stored as glycogen in liver and skeletal muscle. If the imbalance is greater, then our bodies are designed to store that excess energy in a more efficient way as triglyceride. The fat is more efficient because, unlike glycogen, it doesn't need water. And then when metabolized, it generates almost 3 times more energy per gram than does carbohydrates. So deposition of energy in the form of the fat has been promoted by the nature only. And in environments where food is abundant and when individuals tend to be sedentary, the chronic excess of energy intake over expenditure leads to obesity. As obesity is a cumulative pathology. If energy intake exceeds energy expenditure by even a small amount of as little as 7 kilocalories per day, is sufficient to develop obesity over a matter of years or decades. Now coming over to how body weight is regulated. Most of the time, majority of the persons maintain their body weight. And the hypothalamus is the higher center for managing this body weight. A number of hormones secreted from the peripheral tissues, like leptins from the adipocytes, GLP-1 and cholecystokinin from the small intestine, peptide YY, oxyntomodulin from the large intestine. These neurohormonal factors, along with the neuronal signals through the vagus, stimulate the hypothalamus, which leads to satiety. And thus, in the fed state, these are the factors which causes satiety and ultimately prevent further weight gain. Similarly, while in the fasting state, there is loss of the satiety and patient or the person wants to take feeds. I am not able to change the slide, Ajay. So the hypothalamic pathways are there which regulate the body weight from the adipose tissue, leptin, while acting through the leptin receptors, acts on the arcuate nucleus and forms pro-opiomelanocortin. And this POMC derives alpha and beta melanocyte stimulating hormones, acts on the paraventricular nucleus. This leptin also acts on the arcuate nucleus and inhibits the formation of agouti-related peptides. These then reduces the energy intake and increases the energy expenditure. A number of these hormones, in addition to the brain-derived neurotropic factors and the SIM1, all these neuronal signals helps hypothalamus to maintain the body weight. Because of the genetic mutations, these neuronal disruption in these neuronal signals can occur and can lead to the development of hyperphagia and excessive calorie intake and obesity. So majority of the genetic factors act through these brain factors and affect the genes and lead to the development of the obesity later on. So thus genetics or the mutation in the genes try to increase obesity, and which is many of the times is seen in the families. And these genetic factors play a major role in predisposing people to develop obesity. We quite frequently observe high prevalence of obesity in female families. We know this from a large number of studies comparing identical and non-identical twins. Degree of adiposity in adult life of identical twins brought up in different families is very similar between the twins, but is not at all correlated with that of the adopted siblings with whom they were raised. So the siblings, the twins, even brought up in the different atmosphere, they have similar kind of the weight gain. Evidences suggest that this genetic predisposition to obesity is largely mediated through the brain's control of food intake. When studied in controlled settings, individuals who carry genetic variants that predisposes to obesity tends to eat more and less readily get satiated. A number of genetic obesity syndromes are there, including Prader-Willi syndrome, Albright's hereditary osteodystrophy, Bardet-Biedl syndrome, and here we can find a number of genetic mutations which leads to hyperphagia, hypotonia, excessive weight gains. So these genetic mutations are responsible for the weight gain in many of these syndromes. And there are so many other genes or the signals which are involved in the energy balance. And if mutation occurs, that again can lead to the hyperphagia and obesity, like mutations in the leptin gene, leptin receptor gene, pro-opiomelanocortin gene, or the single-minded one gene, or brain-derived neurotropic factors. And these genetic mutations lead to the development of obesity, which is many times seen in the families. So we see that genetic factors are important, but these genetic factors cannot explain the marked increase in prevalence of obesity that has occurred in the past few decades. In most developed and developing countries, energy-dense and high palatable food and beverages are aggressively marketed. They are made cheaper than ever before, and they are provided in larger portions and are made available ubiquitously and continuously. So the easy availability of these energy-dense, highly palatable food, what we call as a junk food, are responsible for excessive calorie intake. This excessive calorie intake is combined with the reduction in physical activity in work and domestic life due to mechanization and the change in the nature of the employment. Taken together, these are likely to be the major factors driving the recent increase in obesity. Diet rich in carbohydrate leads to more weight gain, and diets that are rich in protein and low in carbohydrates more readily results in quick weight loss. Obesity can occur secondary to so many other disorders. Among these, few endocrine disorders are quite common. Insulin resistance leading to hyperinsulinemia is a common cause of obesity and metabolic syndrome. Patients with hypothyroidism, Cushing, insulinoma can also develop obesity. Hypothalamic damage by tumors, inflammatory masses, or severe head injury can cause obesity. Hypogonadism like Klinefelter and other syndromes are also found to be associated with the obesity. Now the question is why we are worried about obesity. Man may be obese, but why we are so much worried? As has already been discussed by many of our seniors before going for this lecture, and it was observed around 2000 years back. Hippocrates recognized that sudden death was more common in those who were fat than in lean, and the risk of mortality and morbidity increases as the degree of obesity and overweight increases. Around 3 lakh deaths in a year are attributed to obesity in United States. More than 80% of these deaths occur among individuals with a BMI greater than 30. Here in this J-shaped curve, we can see that the lowest mortality is observed in the patients who were having the weight in the range of 20 to 25%. BMI was in the range of 20 to 25. With the lower as well as the increase of BMI is directly related with the mortality risk. So obesity is central to individual components of the metabolic syndrome as well as to the characteristic related to the syndrome, such as insulin resistance, thrombogenic tendency, and inflammation. So obesity is related to the metabolic syndrome and is also associated with the morbidity and mortality. Is weight status is related to the disease risk? Yes, it's very much clear. And by this diagram, we can see that in overweight patient, BMI in the range of 25 to 30, slight increase in the disease risk is there. With the further increase of the obesity in the class 1, 2, 3, high, very high, or extremely high disease risk may be there. So we can see that with the increase of the obesity, increase of the BMI, more risk is there for the health. Obesity has been found to be associated with development of diabetes, with the fatty liver disease, hypertension, ischemic heart disease, heart failure, even malignancy, and polycystic ovarian syndrome. How does obesity cause metabolic disease? Obesity is characterized with the chronic imbalance of energy intake, which is more than energy expenditure. So there is expansion of adipose tissue. This leads to the inflammatory markers or inflammation in the adipose tissue, and these inflammatory cytokines leads to defective glucose handling in the liver. Excess fat, in addition to the adipose tissue, is also stored in the non-adipose tissue like that of the pancreas and muscles. This again leads to the abnormal glucose metabolism, insulin resistance, and compensatory hyperinsulinemia and development of the diabetes. A number of comorbidities are associated with the obesities. These include diabetes, obesity, they include diabetes, hypertension, dyslipidemia, cancer risk, liver disease, heart disease, and certain mental problems and joint problems. Is there any link between the type 2 diabetes and obesity? It is very much clear, and around 80% of obese people are more likely to develop type 2 diabetes. Abdominal fat, particularly, has been found to be associated with the release of pro-inflammatory markers and leads to insulin resistance and develop diabetes. Obesity, again, can lead to changes in the body's metabolism, leading to the free fatty acids in the blood, and can also cause insulin resistance. So by many factors, this obesity has been found to be associated with the development of the diabetes. There is a strong association between the central obesity and type 2 diabetes, both in the males and females. Both insulin resistance and hyperinsulinemia correlate positively to visceral fat accumulation, which constitutes an independent risk factor for type 2 diabetes. In this diagram, we can see that after the BMI of the 25, with the further increase in the BMI, there is increased risk for the development of the diabetes, and particularly in the women. And now coming over to whether there is obesity is associated with the dyslipidemia or not. Fat cells, okay, excessive fat deposition in the fat cell can lead to the increase of the free fatty acids, which goes to the liver, causes increased triglyceride, apolipoprotein B and VLDL, and ultimately excess deposition of LDL and small dense LDL particles. Dyslipidemia is one of the most common metabolic disorder associated with the obesity. In diabetics, low HDL and high triglycerides are among the most common features of dyslipidemia. Diabetic dyslipidemia appears to more severe in women than in men, which may explain the excess relative risk of coronary heart disease in diabetic women. Hypertension has again been found to be associated closely with the obesity. The prevalence of the hypertension increases with the weight gain. This bar diagram can clearly show that overweight as compared to the normal weight and obese as compared to the overweight have higher prevalence of the hypertension. And this effect is again more pronouncedly seen in the females. Both male and female develop hypertension more often if they have excess weight. This obesity leads to altered endothelial dysfunction, altered nitric oxide release, increased sympathetic activity, lead to the development of the hypertension. And we have seen in so many patients clinically that weight reduction has been found to be associated with the decrease of the blood pressure or normalization of the hypertension. The prevalence of the obesity-related hypertension. The hypertension we see that is more common among obese and is related with the age also. And if we see that particularly in females, around 50% of the females have obesity-related hypertension, while around 30% of males have around 30% have obesity-related hypertension. So obesity has direct effect on the development of the hypertension, both in men as well as the women, more markedly in women. Is there any correlation of coronary artery disease with the obesity? Yes. There is enough evidence which suggests that truncal obesity has long-term cardiovascular disease risk. Cardiovascular disease risk factors, insulin resistance, dyslipidemia, and inflammation are more markedly present in the obese patients who have central obesity, but it has not been found to be associated with the lag fat. The prevalence of at-risk women is likely more elevated than what is currently recognized through BMI. So not only the BMI, but it is the central fat which also should be considered. These are the data from the prestigious Framingham study, and we can see that development of hypertension is more marked, and the risk for development of hypertension is definitely higher in those in which BMI was higher as compared to the lower BMI patients. It is seen in both in the men above and the marked one, which is for the females. We can see that obese females have more predisposability for development of the hypertension. Now coming over to obesity and obstructive sleep apnea. Obesity has been found to have causal relation with the obstructive sleep apnea. Obesity leads to OSA and various metabolic consequences of it. OSA increases the risk of coronary artery disease, hypertension, type 2 diabetes, sleep disturbances, and hormonal changes. OSA itself can lead to development and progression of the obesity. Central obesity can lead to development of obstructive sleep apnea, and on the other hand, OSA itself can lead to central obesity. Both of these are associated with the insulin resistance, cardiovascular disease, and increase of the inflammatory markers, increased sympathetic activity, and both propagate the effect of the other and increases the chances of development of the other problem. Is the obese women are at risk of infertility? Yes. An obese woman is about thrice as likely to be infertile as a normal woman. It is seen that adolescent obesity is associated with a threefold increased risk. When obesity is strongly associated with the polycystic ovaries, and obesity can lead to the development of decreased receptivity of the endometrium, leading to the infertility. And it also can cause atresia of follicles and apoptosis of the follicles, and ultimately lead to the development of the infertility. Obesity is also associated with the increased inflammatory markers, tumor necrosis factors, increase of the free fatty acid, interleukin 6, increased estrogen and androgen levels, which again, these can contribute to the development of the infertility. Obesity is associated with the insulin resistance, and it leads to the development of hyperandrogenism and enlargement of the ovaries. Obesities can cause decreased SHBG secretion from the liver and can lead to the hyperandrogenization. And similarly, while affecting the brain, it can lead to the hypogonadism and thus can lead to the development of the infertility. So thus we see that obesity affects the reproduction significantly in females. Another important thing is obesity and cancer risk. Obesity, particularly central or visceral, causes insulin resistance and chronic compensatory hyperinsulinemia. Increased insulin levels induce mitogenic effects and contribute to tumorigenesis. Obesity leads to hyperinsulinemia, increased insulin-like growth factor, decreased IGF-BP1/2, and increased free androgen and estrogens. A number of cancers can occur because of the obesity. The most common are the breast, the bowel, the kidney, or the uterine cancers, and of course, gallbladder and pancreas are the other ones. Obesity, because of the altered adipokine production, because of the chronic inflammatory markers, and because of the altered sex hormone metabolism, insulin resistance, and microbiome alteration and microenvironment changes, leads to development of the malignant changes in the cells. Obesity has also been found to be associated with a number of the psychiatric problems. Eating disorders are quite common among obesities. Then anxiety disorders, mood disorders, schizophrenia, all these are more common among obese. And we will not be going into the detail of all of these. So behavioral dysfunctions can lead to the development of weight gain, which again can cause neurobiological alteration and they can result in the neuropsychiatric dysfunctions, and ultimately a number of psychiatric disorders can occur in the obese persons. Obesity has also been found to be associated with the non-alcoholic fatty liver disease, which is much common in the obese in the range of 50 to 90% as compared to non-obese, where it is 15 to 30%. So this prevalence correlates with the obesity rate. Prevalence, this study shows that NAFLD was among nearly two-thirds of the patients who were the young adolescents, and NAFLD was found in the obese adolescents. So this slide has hang, and so this was nearly the we are going to complete this lecture, and in conclusion we can say that obesity has come out as a major health crisis, and if we want to avoid a number of these complications, these obesity should be kept in our mind while the patient comes to us, while they are not obese, recommending them to maintain weight, and if they are obese, we should try to manage the weight in these patients so we can avoid a big number of complications in our obese patients. In the last, I will like to thank you all for the patient listening. Thank you very much. So then our next talk is with Dr. Rakesh, evaluation of obesity.
So good afternoon to all those who have joined today's program. Congratulations to the ICP and Dr. Keswani for organizing such a wonderful program. And I would like to personally thank Dr. Keswani for inviting me to be on this program, to be part of this program. And I also appreciate the excellent talk that he has given on the overview of obesity. What is obesity, what it is, what the problem of obesity today is. Now, I'll go on to discuss about the evaluation of obesity. So in the next 15-20 minutes or so, I'll try to discuss about the evaluation of obesity. So if we look at obesity, it's a complex chronic disease in which abnormal or excess body fat impairs health, increases the risk of long-term medical complications, and reduces lifespan. Obesity has traditionally been viewed as a risk factor for a wide range of other health issues. But now many health authorities consider obesity to be a chronic disease in its own right. So many organizations across the world are now recognizing obesity as a disease rather than a risk factor itself. And that has made a lot of difference. The current practical definition of obesity is determined by calculating the BMI. But we know that BMI is very useful, but has several limitations. So therefore, we need to move beyond the BMI and look at other ways of assessing obesity. So that is something which I'll be discussing today. I'll be discussing quickly about other aspects about assessing obesity. Now, if you look at the physiology of energy and weight balance, in just very simple terms, we can say that, what we are looking at is when there is a balance between the energy intake and the expenditure, then the weight remains constant. But over the years, gradually what happens is that due to several factors, there is a increase in either increase intake or reduce expenditure of energy for the same degree of activity, lesser amount of energy spent, or due to even with small amounts of excess energy accumulation, that leads to significant weight gain over a period of time. And therefore, we see that most individuals tend to gain weight over a period of time. Now, how do we quantify the obesity, or how do we quantify the body fat percentage? So most widely used method is the BMI or the body mass index, which is calculated as the weight in kgs by height in meters, the square of the height in meters. So weight in kgs, if it is 60 divided by the height, if the person is about, say, 150 centimeters, you divide put it as 1.5 into 1.5 as the in meter square, and that gives us the BMI. It's a surrogate measure of body fat. It's a objective parameter, however, to define obesity. Current practical definition of obesity is determined by calculating the BMI, and while we have different cutoff values for identifying obesity, in India we use a cutoff of BMI of as up to 23 as considered as normal, 18 to 23 as normal, 23 to 25 as overweight, and above 25 as obese. So in that category also there are several sort of categorization that is done. Now, looking at body mass index, if you look back at the history, it was earlier called as a Quetelet index. Quetelet index because it was proposed by Adolf Quetelet, and he was the first one to propose this, and later this was renamed. It was used often, and then it was renamed in 1972 as the body mass index. And why is it taken as a cutoff for identifying obesity? It is because what was shown was that there was a J-shaped relationship between the body mass index and mortality from various causes. So if you look at the J-shaped relationship, what we see is that the steep rise in mortality occurs once the BMI increases beyond 30, as you can see here. 25 to 30 itself, there is some increase in the mortality. At below 25, it is low. So above 25, it starts going up a little bit, but after 30, it increases significantly. So that has been the reason why this BMI of 30 is taken as a cutoff for defining obesity. 25 to 30 is said to be overweight, and below 25 is considered to be normal BMI. This is what worldwide we have been using this. This is from WHO, and worldwide literature has been using that. But what is the reason for using different cutoff in Asians or Indians in our population? We have a lot of work from our country which has shown that at the same level of BMI, we are at a higher risk than Caucasian population or other European populations of having diabetes, having cardiovascular disease, having hypertension. So all these metabolic abnormalities that accompany obesity are occurring at a lower BMI. And so therefore, it was shown that looking at the equivalence value for each BMI percentage point and looking at the point of affliction where the BMI where the mortality starts rising above a certain BMI, it was shown that this equivalent value in Indians is lower. And therefore, what we see in this table, which very nicely illustrates the cutoff values. So if you look at Europeans, we say 18.5 to 24.9 as normal weight, whereas in Indians, we would say 17.5 to 22.9 as normal weight. 23 to 25 is overweight, whereas in European populations, it is 25 to 29.9. And 30 and above is obesity, whereas for us it is 25 to 29 is grade 1 obesity, 30 to 35 is class 2 obesity, and class 3 obesity or extreme obesity is beyond 35. So we can see this difference in terms of the risk that we see in our population for metabolic disorders, cardiovascular disease, and mortality. So this is the reason why we need to use lower cutoff values in our population. Now, how do we define obesity in children? In children, although BMI is an accepted measure about 2 years of age, and the other indices that can be used are weight for height. We could use other measures for regional fat distribution, that is weight circumference, waist hip ratio, also in children. The growth standards, growth charts developed by WHO or other organizations like the Indian Academy of Pediatrics also has developed its growth chart. Those can be used for assessing obesity. Now, when you use BMI, what we are saying is that in younger children, we do not use in the age range of 2 to 18 years, we do not use these cutoff values which we use for adults, but what we rather use is we look at the percentile values. So if a BMI is less than 5th percentile for age, then it is called as underweight. A normal weight is 5th to 95th percentile, 5th to 85th, 95th percentile, and from 85th to 95th percentile. 5th to 85th percentile is considered normal. 85 to 95 percentile, we are saying overweight, and above 95th percentile, we are taking it as obesity. And if it is more than 120 percentile, 120th percentile, that is severe obesity, class 2 obesity, and class 3 obesity is more than 140th percentile. So that is how you would take the percentile rather than taking the actual cut. Any cutoff figure for the BMI value. And you can classify obesity, as we said, that below children below 2 years of age, you would use weight for recumbent length. If it is more than 97.7 percentile of the WHO standard, then you will call it as obesity. In about 2 to 20 years, we are using the BMI cutoff, BMI percentiles as I've just mentioned. So having looked at that, let us look at the classification of obesity based on BMI percentiles. I have just mentioned that 95th percentile, 120 to 140 being class 2 obesity, and more than 140 being class 3 obesity. What are the limitations of BMI? BMI, can it be used by everybody? We say that BMI is a useful parameter which is easy to calculate. It has been used by many people across the globe. And but what we see is that we understand that there are some limitations of BMI because it's not a direct measure of body fat, cardiovascular risk, or health. It does not indicate the fat distribution also. It indicates that there is increased fat, but it doesn't indicate increases the, it says that there is increased weight. It even does not measure the fat. We are postulating that it is because of fat increase. It does not account for muscle mass. So there could be individuals who have got sarcopenia, that is, they have low muscle mass, their body fat percentage is more. So that is not picked up by the BMI. It underestimates the body fat in people who have lost muscle mass. That is those who have got sarcopenic obesity. It does not distinguish between men, women, or ethnicity. And BMI overestimates or underestimates the body fat in certain ethnic groups such as the South Asians, Chinese, and other population. It is not accurate in older individuals, those with kyphosis because of which there is a decline in height, or those who have those who are volume overloaded states, like where they have got fluid accumulation, CCF, nephrotic syndrome, chronic liver disease. In all these situations, what happens is the weight is overestimated because of the volume overload, and once that is cleared, their weight comes down. So that's not the actual weight of the individual. A lot of weight of the water is added on. Now, another interesting aspect that is understood about the BMI is that you see, if you look at this picture, you see two different individuals. One is Professor Yajnik and Professor Yutkin. So we see that both of them share the same BMI, 22.3. But if you look at their body fat percentages on measured on DEXA, you find that for Dr. Yutkin, the body fat is only about 9.11. And Dr. Yajnik had a body fat percentage of 21.2. So this actually brings out the stark difference that could be there in terms of the body fat percentage with the same BMI. And it says that this is one of the limiting factors of BMI in not being able to identify the fat distribution and the fat content. Based on understanding of fat distribution, fat content, we understand that obesity has different phenotypes. That is, there could be people who are otherwise normal by BMI. Those who are normal by BMI, that is 18.5 to 25, as you can see in the two categories here, two middle categories here, you can see metabolically obese normal weight people who are having a normal BMI, but they have high visceral adipose tissue, and their lean mass is however normal, and their metabolic abnormalities are present. They have metabolic abnormalities, so they are metabolically obese but they're normal weight. Similarly, you have got normal weight people who are appearing normal weight but who are obese because they have got high visceral adipose tissue. Their muscle mass is coming down, their visceral adipose tissue is increased, and they are normal weight obese people. That is, they're called normal weight obese because they don't have the metabolic abnormalities. Once they start developing metabolic abnormalities, then we call it as a metabolically unhealthy obese, unhealthy individuals. So we could have either way. They could have people who have got normal weight, but they have metabolically abnormal, but they could be people who are normal weight who are metabolically normal. Now you have got metabolically healthy obese where when their obesity is there, but metabolic abnormalities are not there. So they are metabolically healthy obese. But what we see is, are they safe? They are probably not safe. Long-term follow-up data has shown that these people tend to progress to metabolically unhealthy state. And so therefore that is a phase in transition. Now you have got sarcopenic obesity where you have got where the BMI is increased, the visceral fat is increased, the lean mass is decreased. So they are actually sarcopenic and at the same time obese. So we have got all these different categories of individuals now based on the assessment of the BMI and also assessment of the body fat distribution and the metabolic abnormalities. So based on this, we could say that there are different categories of obesity. So what are the other methods to quantify obesity? We could use the waist circumference, waist to hip ratio. We could use the neck circumference, the neck to height ratio, and skin fold thickness. These are other simple tools that can be used to assess obesity or evaluate obesity. So waist circumference is a measure of the abdominal obesity and provides independent risk information, and that is not accounted for by the BMI. Patients with abdominal obesity are at increased risk of heart disease and diabetes. And they also have a high risk for hypertension, dyslipidemia, non-alcoholic fatty liver disease, and high overall mortality rates. A waist circumference of more than 102 centimeters for males and more than 88 centimeters of females is considered abnormal. Worldwide, this is the category that is used by WHO and IDF. But with for Asian Indians, we see that males should have a males with a waist circumference of more than 90 centimeters, and females with a waist circumference of more than 80 centimeters are at higher metabolic risk, and therefore that should be considered abnormal. So when do you measure the waist circumference? As you can see here, measuring is very important. You should remove the clothing from the waistline and then stand with feet shoulder wide apart, and then you measure the look at the inferior, palpate the abdomen to locate the inferior margin of the last rib at the level of the mid axillary line. Then palpate and identify the crest of the ilium on both sides. Use the area in between the thumb and the index finger. The 2 points you've noted down, you marked out, and then you are taking a point midway between this, and you measure the waist circumference. And you ask the patient to have 2 normal breaths, and on exhaling after the second breath, you tighten the tape to measure the waist circumference. You hold the tape snugly, but not very tightly. So looking at that, you can, this is how you should measure the waist, and the hip is measured at the level of the greater trochanter. So there are some disadvantages and advantages of waist circumference measurement. It correlates very well with metabolic and cardiovascular disease, because it correlates with it is giving a surrogate measure of the abdominal fat distribution. An increase in waist circumference is reflective of adipose tissue dysfunction. It correlates well with total abdominal fat. It's a simple measure. It doesn't cost anything, just requires a tape which you use for measurement. But the problem is that measurements are not always reproducible. As we said, that there is a lot of subjective bias in measurement, in the sense that different individuals may measure at different positions, and so that variability is there, inter-observer variability is there. And there are racial ethnic differences in the cutoff points, and it does not again differentiate, although it says that there is abdominal fat, but it does not tell us whether it's visceral abdominal fat or is it subcutaneous abdominal fat. So that is the problem with the waist circumference, and so therefore we need to add it on. Although it has some disadvantages, but it has some advantages over the BMI, because BMI is what we have problems like you require. You do not get a proper estimation of the visceral fat content. You don't know about the fat distribution also. We don't know about the fat content also. So all these things are the limitations of BMI, but there could be, there are problems with doing the waist circumference also in terms of variability, and therefore we need to recheck the BMI at least, the waist circumference at least 2-3 times, and the 2 of the 3 are taken, average of that is taken. So it's a stronger predictor of health risk in individuals, and it's a predictor of the total body fat related health risks at a population level. Now, if you look at the waist and hip circumference, as I told you, some people use this ratio because that may they feel that it gives a better information. But if you're looking at the ratio, you're looking at a ratio of more than 0.9 for women, and 0.8 being considered normal for women, and more than 0.9 considered abnormal. That is in the Asian cutoffs. In Caucasian cutoffs, you're using 0.9 and 1. The international Interheart study proposed that WHO is a better adiposity risk marker for acute myocardial infarction. So this has been validated in this large cohort of the Interheart study. And however, limitations are because it cannot distinguish between subcutaneous and visceral fat. It makes it difficult to assess the visceral fat itself with the measurement of this. Now, to overcome the problems of sort of take off their clothing around the waist and allow the measurement of the waist circumference, and therefore what is also been looked at is whether measuring the neck circumference can be useful. And it has been shown in various studies that neck circumference is also a good marker of insulin resistance and metabolic abnormalities. So where do you measure that? You measure it at the mid neck, between the mid cervical and spine and the mid anterior neck, on standing upright and facing forwards with the shoulder relaxed. In men with a laryngeal prominence, it must be measured with just below the prominence. So that is how you measure the neck circumference. Neck circumference of greater than 16.5 inches is a useful predictor of OSA and metabolic disorders. It has been shown in different studies that a value of more than 36.5 centimeters for males and more than 34.05 centimeters for females has a maximum sensitivity and specificity to predict overweight and obesity in relation to different body fat estimations that we have done. So 36.5 and 34 centimeters in males and females respectively. Now you can also use a neck to height ratio also. So that ratio, if you're looking at neck circumference of 34.9 and ratio of 21.17 centimeters per meter height is considered to be a risk marker. Beyond that is considered to be a risk for cardiovascular and metabolic syndrome, and particularly we have correlated in various studies with metabolic syndrome, occurrence of metabolic syndrome. So clearly we have a good marker, which is the neck circumference and the neck to height ratio. Skin fold thickness can also be used. Skin fold thickness provides a useful estimate of the body fat, and skin fold ratios have been proposed for looking at the fat distribution. Some of the skin fold measures that we generally measure are the subscapular and the triceps, over the triceps, and this is and these have been good measures of central distribution of fat, and others have been correlated with subcutaneous abdominal fat. However, measurements of skin fold thickness are again fallacious sometimes because of there could be subjective variations in this measurement, and sometimes there's a problem when the thickness exceeds the width of the caliper. Can we use CT or MRI? That is again one of the modalities that are being used, and in these techniques you obtain a single cross-sectional image at the L4 L5 interspace, and you can then measure the fat content in that. You have softwares which can identify the fat and can give you a fat percentage at that point. However, it can also be done some places where you don't have the software available. They even do it manually, where they look at the fat content and they separate it out from the muscle content and the other viscera, and the fat percentage can be calculated. The fat volume is estimated from a single slice based on regression equations, and this can be the regression equations and programs can be available. Software programs are available to do it at within no time at very low, with a low risk of exposure to radiation. However, imaging is expensive and can be problematic for people who are claustrophobic, and so therefore, although there are some advantages, this has its own limitations. Then we have the densitometry. Total body fat can be measured classically by densitometry based on Archimedes' principle of water displacement, assuming just two body compartments, that is fat and muscle. Based on that, we can say that using this principle, if two individuals of the same weight on land have different proportions of body fat and lean tissue mass, the one with more fat and less lean mass would weigh less underwater. So you're weighing weighing underwater and comparing it with the usual weight of the individual and trying to understand the density, understand the fat and muscle content or the lean content. So this requires underwater weighing facilities and is also time consuming. So it is expensive. Many people would not like to be submerged in water, so it cannot be a simple measure of body fat percentage, although it gives us useful information, and this can be sort of analyzed and we can have a better understanding about the fat distribution. The other technique is bioimpedance. Obese people have increased lean body mass as well as increased fat mass, and what we see is bioimpedance assesses total body water crudely as a component of lean body mass. Therefore, estimation of fat mass by this technique is relatively weak, but it can be used and it is often used. And we have got a bioimpedance spectroscopy also that can also be used to measure the lean mass, and the body fat percentages can be measured. Then we have other techniques like the near infrared interference. So this measures the body fat by assessing the absorption of infrared light. The amount of absorption and reflection of infrared light is related to the composition of the underlying tissue. And we have prediction equations using the data that is obtained from this near infrared interference. And this has, however, not been validated very well. But although this is a promising way of measuring that, it has not been validated very well. One of the most validated processes for measuring the body fat percentage and the body fat distribution is the dual energy X-ray absorptiometry. It's a method which can help in determining the body fat percentage, the distribution of fat, whether it is in the visceral compartment or whether it's in subcutaneous compartment. What is the distribution of fat in the arms, the legs, and other body compartments can be measured from using the DEXA, or the dual energy X-ray absorptiometry, as we call it. And this, while traditionally being used for measuring the bone density, it can also be used for measuring the body composition, as we have seen. So we have, having looked at all these things, we have just seen that all these things have advantages, disadvantages, all these measurements that we've done. So what is proposed is a more unified way of assessing obesity and its impact on metabolic health by looking at what is called the Edmonton obesity staging system. So the elements of this are to guide clinical decisions on from obesity assessment at each BMI category. So Edmonton obesity staging system is a measure of the mental, metabolic, and physical impact that obesity has on a patient's health, and uses these factors to determine their stage of obesity. And you can stage people from 0 to 4. In population studies, this scoring system has been shown to be a better predictor of all-cause mortality when compared to just the BMI or the waist circumference. So that's the reason why this has become a very popular system of staging obesity. As you can see here, you have the stages from 0 to 4, and you put patients are classified into these stages based on 3 parameters: their medical issues, then their mental issues, and their functional status. So these are all important, because somebody could be very obese, but may not have other medical issues, and may not be maybe mentally very strong, maybe sort of normal, and have no functional issues. So this person, just because the BMI would be in a very extreme obesity, but he may not actually be functionally doing well, and maybe falling in a lower stage of obesity. So what we are saying is that when there is no medical problem, then it is stage 0, along with no mental or functional problems. But when the person starts having preclinical risk factors for various disorders, like for developing pre-diabetes or a lipid abnormality, all this will put them in stage 1, where these are present along with mild mental disturbances or stresses, mild mental stresses, and functional impairment being there. Mild functional impairment, if it is there, then it becomes stage 1. Stage 2 is in the presence of other comorbidities with moderate mental dysfunction and moderate function involvement. So that becomes stage 2. Stage 3, as you go on, you have stage 3, and stage 4 is a stage where you have significant medical issues, you have mental health issues, and you also have a poor functional status. So that becomes stage 4 of obesity. So this Edmonton staging system actually puts into perspective or brings into perspective not just the BMI, but also the functional status of the individual, the other coexisting metabolic or other abnormalities, other problems that the patient has, health issues that the patient has, and also looks at the functional status. And therefore, it gives a more comprehensive assessment of obesity. The other assessments tools which are there, which I'm just mentioning, that because there's a stop bank tool where you can use this to assess the risk for obstructive sleep apnea. Now, as you know, obstructive sleep apnea has been found to be a very strong risk factor for development of diabetes, cardiovascular disease, and various other problems, metabolic problems. It has been shown to correlate very well, and therefore, what we need to use is a scoring system called the stop bank scoring system. If it is a score of more than 4, it indicates there is need for referral for management of sleep apnea. Finally, before I conclude, I would like to say that a good physical examination, good history, good physical examination, good history, particularly focusing on the the age of onset obesity, the type of pattern of weight gain that is there, the food eating habits of the person, the previous weight loss attempts and response to interventions. All these information should be captured, and if we are able to capture that information very well, we'll be able to identify many individuals who have underlying problems, which are the causes for obesity, and excludes those people who do not have these problems, and obesity may be just pure exogenous obesity because of it, imbalance between the energy intake and expenditure. Then we need to look at the physical activities, screen for depression, anxiety, look for psychological impact of previous weight journey, addictions, history of addiction, sleep history, and medication history. All these are very important aspects that have to be kept in mind when we are evaluating people with obesity. Different sorts of symptoms can be correlated, as you can see here, can correlate with the the underlying problem or medical problem that we are looking at. We are searching for. I mean, we are trying to exclude. Then laboratory assessment is very important because we through this we can exclude certain problems like thyroid dysfunction, which may not be the usual cause of obesity, but in a few patients, in a small number of patients, maybe there could be a thyroid dysfunction, or you need to look at the renal function test, liver function test, the lipid profile, the uric acid levels, the 2D echo. Would help us in better understanding of the reasons for obesity, if there's any, and picking up any of the private any of the other reasons for secondary causes for obesity. That is, if you have endocrine disorders which stand out, which come out as significant. That is, if you have got features of Cushing's syndrome, you have got proximal muscle weakness along with the weight gain, and you have a laboratory evaluation done for that, then it probably requires a little different management, and certainly does not require requires a different management. So these are things which have to be screened when you're screening people for obesity. We need to take a good history, thorough physical examination, look for investigations based on the physical examination findings and the history that you've taken, and based on this you need to screen for other underlying conditions which could be spreading obesity. In the absence of that, it is because of endogenous obesity, because of the imbalance in the various aspects that we have discussed about earlier. So finally, I would like to conclude by saying that identifying people who are overweight, and particularly with excess accumulation of excessive visceral fat, is essential for directing future interventions. BMI and waist circumference are well validated and available to all healthcare professionals. Waist circumference is arguably better, but both are simple, and change is best monitored by following the body weight. More recent methods like bioimpedance and DEXA for assessing the body fat distribution are currently in research domain, but will certainly in the future become very useful measures of understanding the body fat distribution and understanding the benefits of weight reduction and the other measures done for treatment of obesity. With that, I'll conclude. I thank you all for the patient hearing. I'll be happy to take any questions if there are.
Thank you, Dr. Rakesh. Really, it was a very nice presentation, and you tried to tell about all the things about how we can see for the different types of the obesity, phenotypes of the obesity, how can we measure different portions of the obesity in different parts of the body, and what is their relevance to the disease and comorbidities. And if there are any questions, you can ask. So in chat box, I can see that Geeta Arora has given that what can be the relation of the gut microbiome with the circadian rhythm. Gut microbiome come out as an important organ, and many of the enzymes and products from the gut microbiomes affect the hormones and the energy uptake from the intestine, and has been found to be related with the development of various other metabolic diseases and neurohormonal effects are there. As such, there cannot be any relation with the obesity and circadianism with the gut microbiome, but the gut microbiome has been found to be associated with the calorie absorption and weight gain. Any other questions if there are? So Dr. Rakesh, it was a nice presentation of how we can evaluate the obesity. And next week again on Sunday on 30th April, we will have two eminent speakers talking on the different aspects of the obesity. And I think that all those who have sent requests for the registration, their registration has been made and they must have got the link also and must have been added to the WhatsApp group of obesity. Just who have not been added will be added in the next few days. And if any of your friends have not got registered or not got joined in the WhatsApp group, please try to inform about your friend. So we will also add them. And next week again, we meet around 2:30 p.m. again on this group, and the link will be sent to you all at least one day before it. Thank you all for joining us. Hopefully we will go through this series of lectures and at least we will have some information about the obesity. When we will be seeing our patient of the obesity, we will have something in our mind that this obesity or truncal obesity is harmful for my patient and I should warn my patient, I should try to reduce the weight of my patient. So this can help our patients and also our practice. Thank you all for being with us. And next week again we meet.
Thank you very much.
Any comments?